So why is it important? Well, we know that colonoscopies offer greater protection for the left versus the right cancer. This is slightly older data now, but from the cancer registry data analysis from the 70s to 98, important publication by Rabenek showing that right-sided cancers were unchanged. So colonoscopies weren't helping to protect against right-sided cancers, whereas left-sided cancers, there was definite incidence reduction if you'd had a colonoscopy. Likewise, there was further evidence from Brenner's paper looking at reduced incidence in the left but not the right-sided cancers if colonoscopy performed in the last 10 years. So something's happening here in that we are not protecting against the right colon and not potentially not seeing things in the right colon. So this is the percentage of cancers that are found in the colon, and you'll see from the caecal pole 14.6%, and I would argue that's proportionately greater than other sections of the colon because the cecum is a relatively small area. So we really need to be spending some time looking at this area, looking for polyps, looking for early cancers. So how to do it? Well, first thing is to move the patient usually into the right lateral position because the cecum often sits medially, and moving into the right lateral allows the fluid to drain into the ascending colon and the air to come into the caecal pole to improve views. So slow insertion into the caecal pole with suction, torque and a deep breath to get down into the caecal pole, I think are good techniques to get that deep caecal pole intubation. I think when you've got a nice open sort of arching scope, sort of heading in the ascending colon, then stiffener can sometimes help, and pressure is often helpful in this.
So I think these questions, why should I retroflex in the right colon? So I've got to the cecum. I'm very happy. I'm very pleased that my photo shows that. I've ticked all the boxes. I've got my KPIs. Why? And actually, my list is running a bit late. So why should I? And, I think the answer to this is because we know that we miss lots of cancers and pathology in the right colon. There are questions around, should I just do a double pass in forward view? Because actually that's going to be really easy for me. But I think, and actually it's not something that I do routinely, although I'm trying to do it more and get better practice at it. So in order to retroflex, we need to come to the anal side of the ileocecal valve so that we're not retroflexing in the deep caecal pole. So we'll do tip fully up, move the wheels as well, and then use usually anti-clockwise torque to pull back. Patient position here, I think for me would be left lateral. So the fluid has drained out of the right colon, and we'd aiming to come back to the hepatic flexure really slowly and using torque to visualize in a circular fashion around all of the folds, making sure that we've seen behind every fold.
But I just want to tell you this because I think it's really important, and we just need to address this. And I would urge people just to think before they act, if you like, because you have to think, well, what's the natural history of this polyp? It's probably a 15, 17-year history. She's 81. Yeah. If she was my mother, would I want, so that's what goes through my head. Now, we published a case. I think the patient was actually a bit older than 85. But she came back for a surveillance colonoscopy. It hadn't been validated that she should. And she had some cognitive difficulties. And the procedure was done by a locum. And he used a hot technique to remove a small polyp. And the patient comes back 3 or 4 days later with abdominal pain, has a perforation in the right colon, has a right hemicolectomy, and then dies. Right? So it's not without consequence sometimes. So basically, we reviewed our processes around this. And what we decided, relevant to what you're saying, Steve, is that if a polyp is of a reasonable size in an older patient, i.e. more than 1 centimetre, it is reasonable to remove it. But we decided that a policy for the over 85s, not 81s, but over 85s, is that we would not remove diminutive polyps.
I think that's reasonable.
So, and this is all based on the subsequent potential risk of a 1 centimetre plus lesion. So I would urge all of you to be thinking, you're all eager to keep your adenoma detection rate up, but just think about the patient and the reasons we're doing things, and just not lose sight of doing something sensible and thinking, well, what would you want your parent to have? And the patient comes back 3 or 4 days later with abdominal pain, has a perforation in the right colon, has a right hemicolectomy, and then dies. Right? So it's not without consequence sometimes.
So if we put pressure, this
I want everybody to watch the blue screen.
That's it. There we go. So that's pressure now. It's going to stop that lateral transverse pressure going. It's going to go nice. Then it's going to go nice and slowly.
Again, see the movement on the descending colon there, bulging laterally now, and then with compression, really stopping that bulging to the left. And this is in larger people. Dare I say, this is not an uncommon place for bowing of the scope, and the effect of compression can be absolutely dramatic. But here there's obviously a lot of anterior movement of the transverse, isn't there?
So what we're going to do is both here. So
you need to do both.
That's brilliant. You can push flat there as well. Pull in as you were, but with the other hand, flat down. So we're going to put 2 lots of pressure on here to see if we can stop the anterior component of the bone as well as the lateral.
Yes.
There you go.
And there we go.
Look at that. I mean, that's dramatic.
Wow.